So my name is David Josephson, and I'll be talking about kidney cancer, the management with robotically assisted laparoscopic partial nephrectomy, and the impact of fluorescence. This is the incidence of renal cell carcinoma, approximately 60,000 cases in the United States per year, accounting for almost 13,000 deaths per year. The majority of these cases are detected incidentally because of the proliferation of imaging such as CT scan and MRI. In the past 3 decades, we've noted an increase in incidence, downward stage migration, an increase in interventions available, yet we still have almost 40% increase in annual mortality from the disease. Nephrectomy is considered the standard of care for clinically localized renal cell carcinoma. This really has to do with the incomplete effectiveness of systemic therapy. They're not curative. They're more control disease that is metastatic. Radical or partial performed nephrectomy have good long-term cancer-specific survival rates, especially in lower stage disease, and a minimally invasive laparoscopic approach has comparable outcomes to the open approach. We know that a fourth of the patients with renal masses or renal cell carcinoma do present with pre-existing renal insufficiency, and up to almost 70% of patients after radical nephrectomy will have some form of renal insufficiency down the line. Although surgery remains the mainstay of treatment for localized renal cell carcinoma, open radical nephrectomy is arguably no longer the gold standard. It has known procedure-related morbidity such as pain, longer recovery, and can lead to renal insufficiency, just as I mentioned. With the open approach, a lymph node dissection is certainly more feasible, but it should be known that the role of this in all patients is controversial. Certainly, several alternatives to the open approach have become available to reduce or avoid these inherent negative consequences. And these are different pictures of what an open radical nephrectomy incision can look like. This is a modified thoracoabdominal incision. This is a subcostal incision. And lastly, this is what a full retroperitoneal lymph node dissection looks like. Laparoscopic and hand-assisted laparoscopic radical nephrectomy have clearly demonstrated equivalent long-term oncological outcomes to open radical nephrectomy in carefully selected patients. Whatever the approach, whether transperitoneal or retroperitoneal, the laparoscopic approach duplicates the principles of the open technique: early control of the renal artery and vein, en bloc removal of all perinephric fat with or without a concomitant adrenalectomy. The laparoscopic approach is associated with quicker convalescence, decreased pain management requirements, decreased hospital costs, and it has been suggested to become the new gold standard surgical modality in the treatment of localized renal cell carcinoma. But this again is being reconsidered given the plethora of new data showing the harmful effects of radical nephrectomy on chronic kidney disease and its subsequent effects on cardiovascular related morbidity and death, especially in the setting of small renal masses, or what I consider to be the T1 stage category. These are some relative contraindications to proceed with a laparoscopic radical nephrectomy, certainly when a nephron sparing approach is indicated, when you have a locally advanced tumor invading surrounding structures, the presence of a thrombus beyond the renal vein into the vena cava, and certainly the size of the tumor as it relates to the operative space. The presence of lymphadenopathy is questionable because there are institutions, including my own, where we've performed the regional lymph node dissection in the setting of high-risk disease by using minimally invasive techniques. So I'm going to switch gears now to just talk about small renal masses. It should be noted that the biology of these tumors is heterogeneous, and there are multiple management options available, ranging from observation to radical nephrectomy. Given the significant heterogeneity in the biological aggressiveness of clinical stage 1 renal masses and the wide range of treatment options now available, Renal mass biopsy should be used more commonly for patient counseling and clinical decision making. The confirmation of suspected RCC is one indication to do a biopsy when the surgical risk in the patient is extremely high, when you have locally advanced disease and the tumor may be unresectable, when you have concomitant metastatic disease, and when ablation therapy is being offered. Certainly in masses with equivocal findings on CT or MRI are also candidates for pre-treatment biopsy. Certainly any mass in a solitary or transplant kidney should be biopsied before treatment. And if anyone's had a extrarenal cancer, a biopsy should also be performed. This is a CT scan of a patient who presented with a left renal mass. The appearance of this is not very consistent with a typical renal cell carcinoma, and sure enough, the biopsy of this was consistent with a lymphoma. This patient avoided getting an unnecessary nephrectomy and proceeded with systemic chemotherapy. These are some of the options in management of small renal masses: active surveillance, cryo and radiofrequency ablation, and surgical excision, whether partial or radical nephrectomy done in open, pure laparoscopic, robotically assisted, or through single port techniques. Just briefly talking about surveillance. Indications for surveillance are elderly patients with decreased life expectancy and comorbidities, which increase the risk if any intervention is undertaken. It also allows a period of observation with delayed intervention to determine the growth rate of a lesion, and certainly a judicious period of active surveillance appears to be associated with a low risk of size or stage progression while maintaining most therapeutic options to be used down the line. However, the patient should be counseled about the small but real risk of cancer progression and possible loss of window of opportunity for nephron-sparing surgery, potentially in the setting if a metastasis does develop. These are some of the historical imperative conditions to proceed with nephron-sparing surgery, also known as partial nephrectomy. Historically, a small tumor size with a cutoff of 4 centimeters was a guideline, but we now promote partial nephrectomy in masses even larger when there are conditions that place the patient at risk for worsening renal insufficiency or being placed on hemodialysis permanently. Imperative indications are solitary kidney, bilateral or familial forms of renal cell carcinoma, pre-existing chronic renal insufficiency, or the presence of hypertension, diabetes, or any other comorbid condition likely to impact down the line renal function. Regardless of the indication, the treatment of isolated renal cell carcinoma with open partial nephrectomy seems to have equivalent oncological results to radical nephrectomy while minimizing the degree of renal function change related to tumor resection. These outcomes have been shown primarily in treating tumors of 4 centimeters or less, although there's recent data that suggests that bigger tumors up to 7 centimeters can also be addressed using open partial nephrectomy with similar results. There's excellent cancer-specific survival rates with partial nephrectomy. However, the partial nephrectomy approach is associated with increased morbidity and complications in up to 30% of patients, including hemorrhage, urinary fistula, obstruction, infection, and a small degree of renal insufficiency. So, to reduce the morbidity of open partial nephrectomy, which is being shown in this video here, a pure laparoscopic partial nephrectomy has also been performed and evaluated. Certainly, there are advantages such as quicker convalescence, less pain management requirements, and better cosmesis. However, the disadvantages are that there's a lack of uniform way to do the cold ischemia to replicate the open technique. Pure laparoscopic approach is technically challenging, and there's a very steep learning curve associated with this technique. Also, there are higher rates of